My name is Eunice Ojo. I'm co-chair of Aging Gerontological Research Interest and Implementation Group of the SNRS, Southern Nursing Research Society. Our goal in this group is to promote the advancement of research for the care of older individuals using innovative approaches to guide and promote the care of healthy, chronically ill, and frail older adults. So we have a speaker, Dr. Lodge, for this webinar today, and she is well prepared to speak to us today. Before we start, I would like to do a quick introduction of Dr. Lodge. Dr. Stephanie Lodge is an adult health nurse practitioner. She graduated from Texas Women's University with a PhD in nursing science, Emory University with an MSN, Duke University with a BSN, and Agnes Scott College with a BA in history. Her current practice is as a clinician for an epidemiological study and clinical trials in aging. While on the data team for the Health and Aging Brain Health Disparity Study, she facilitated the transition from paper charting to an electronic data capture system, reviewed data for quality, and assisted researchers with questions about the data. She is a founding faculty member of the University of North Texas Health Science Center's College of Nursing. Her interests include research intersecting aging and informatics, data methods, and working with students to develop research questions. So join me to welcome Dr. Lodge for today's webinar.
Hi, thank you, Eunice. That was such a wonderful introduction, and I'm going to go ahead and share my screen. I'm Dr. Steph Lodge, and first let's see if I can share it, if it'll work. It says it's not sharing, it's not turned on. There. Give us just a sec. Thank you all for your patience, and
can you try it one more time?
I will totally try it one more time. It says share. The host isn't allowing multiple presenters sharing in this meeting.
Okay. Let me see if she's here. That's Casey.
And this is a topic that I'm really stoked to talk about because it's something that I really enjoy.
That's okay.
Yeah.
I'm reaching out to Casey to make sure that we can.
Not a problem. Or you can, if it's easier for you to share the screen, that's fine too.
I tried it and won't let me.
Did you? Of
Yeah.
course. I'm totally cool.
Also disable participant screen sharing.
All right. Well, thank you, everybody. If not, I can always talk through the slides if we can't get it to work.
I hope she will respond.
We'll give it a couple minutes. If not, I can just talk through the slides. So it's
let's just wait 2-3 minutes, then
we can get started. It's all good.
Mm-hmm.
The only thing that you'll miss when you don't see the slides is some of the fun case study stuff that I did. I created some fun graphs, but otherwise it's all good.
Okay.
Eunice, you can click participants and then you can click Stephanie Lodge. And then right side, you can set up Stephanie to be the co-host. And then Stephanie can share by herself.
But I don't
think-
have,
There is
I
no
don't-
host in this meeting.
I'm not the host. It's Casey from SNRS.
That's the problem. Eunice can't change it. So Eunice can't host
Yeah.
it either. So even though she has the slides, she can't do
Yes,
it.
I have the
It's-
slide, but she
Yeah.
didn't give us the permission to share this one. I hope she will respond. I already messaged her.
You know, Eunice, you're doing great. We really appreciate your patience. And thank you to everybody else for the
Thank
patience
you.
with this. Well, because as we
Thank-
know,
Thanks
the
to
controls,
everybody. Thank you for your patience.
we really appreciate it. And you know,
Okay,
Hey, handsome. Hi, boo boo.
let me try one more time. No, she won't let me do it.
Great Trace. Hey, Great Trace.
Okay, so Dr. Lodge, do you want to start? And
I can totally start, guys. Now
if
you
she
guys, this-
responds, I will let you know. Then we can-
totally, it's totally all right.
because of-
So I'm Dr. Steph Large, and we're going to be talking about data methods in aging research from collection to analysis. And the objectives are to describe recruitment methods, apply clinical trial methods to research, and examine best practice methods for data collection and utilization. A reason for this is that clinical trial methods are the gold standard for research, and these are methods that you might not know about as you're doing research. For example, when I started with the epidemiological study, I didn't know the clinical trial methodology, and it's a good framework for evaluating research and conceptualizing research practices. We'll start with knowing your population. You want to learn about your population and connect with your population. Older adults are not monolithic. The population varies. One wants to look at learning through being present in the community and making authentic connections. Nurses are excellent at this. We excel at having an authentic conversation with the patient and moving beyond the concept of, I want to study a group of people to either intervene or improve their lives, moving from that I to a we. How do we work within our communities to improve care? An example of knowing your population is looking at older adults in the context of their communities. For example, smartphone utilization. When we look at smartphones, a lot of older adults use it. Let's say you have this cool idea, I have this new intervention, but it uses a lot of data. So for example, how much does a data plan cost? Can the older adult afford the data? Can they afford to use it? Can they afford to send those messages through that application? And do they have the fine motor skills in clicking the buttons? Pushing the buttons requires a level of fine motor skills that can be limited through neurological disorders or through arthritis. Next part is good clinical practice. The aim of good clinical practice is to protect public health and research participants, and it comprises laws that govern regulations, guidelines that are regularly accepted practice, not legal rules, and local laws, regional, state, and city. These guidelines were first published in 1996 and amended in 2016. It's not required, but they talk about strict guidelines for ethical conduct. Holding oneself accountable to the highest standard allows us to conduct research in communities and protect ourselves from making unethical decisions and also protecting patients. It's easy to sometimes not look at, oh yes. It's easy to sometimes not look at that in that context, and it's better to follow guidelines that give you stricter rules than rules that are more lax. And recruiting, it's not just about enrolling. recruitment. We're going back to teaching and we're going to talk about formative assessing. You want to perform formative assessments. Formative assessments meaning assessing during. Does your recruitment strategy work? Is it cost effective? There's the article, and it's in my, if you would see the slides, by Kurkowski, and they do a great job of showing how eligibility criteria can affect enrollment, because the eligibility criteria creates a selection bias. It would be great and wonderful if we could create a study that studies everything all at once instantaneously, but we're limited by how much time and effort affects the willingness of a patient. What is the patient burden and what is the selection bias from that burden? Informed consent. This is a process in which a subject confirms voluntarily that they want to participate in a study. They need to be given relevant information to their personal decision-making process. It's generally a document that's dated, written, signed, called an informed consent form. Liu and Davis on page 74 call it an informed decision-making process. And I really like this conceptualization of this because it is a process. It's not simply giving information, having someone sign it and saying, let's go do. Vulnerable populations receive special consideration, and be extra careful navigating that so that those vulnerable populations aren't taken advantage of and they truly understand what they are consenting to and what their options are. When one performs the informed consent, even if it's a study where you're not getting a lot of information that poses risk, let's say it's online, you still want to go slow. If the informed consent is online, make sure that it loads and someone has the time to read through it. A person should be able to perform this in a private place. If you're doing it in person or with someone, make sure you explain everything because that's important. The patient or the participant needs to have enough knowledge that's relevant to their own decision-making process. And then if you're explaining something as you're going through or you're doing it in person, you want to assess the subject's understanding. This is where teach-back. Nurses have a skill set of the teach-back method. That's how you're going to assess it and ensure that they're not just saying sure. And then if they say sure and they're not truly understanding it, a year later, they might go, I didn't sign up for this. This was unexpected. And that's not really fair to them either. It's not fair to you or them. The protocol, I'm going to talk a little bit about that. This provides the framework for any study. It's how it's organized. Common components. You're going to have a background and a rationale. What's the history? How do you get to where you are? How is the study organized? Who does what? What's the implementation plan? How are you going to do it? What are the visit schedules? Is it just a one-time, hey, I'm doing a survey questionnaire, sending it out? Or are they responding again to multiple surveys? How are you de-identifying the information? How are you ensuring adequate privacy? Types of personnel, even if it's one person, what are all the steps that that person is responsible for and doing? If you have multiple people, what specific aspects of the study are they performing? What's in their scope? And the bigger the project, the more people you have, the more specific you need to be. And you want to make sure it's clear because that allows the folks reviewing it at IRB to know what's going on. And it also allows your study personnel to know their scope of work. And that way you have clear objectives that you can reach, and you also allow for accountability. The objectives. This is the point of the study. Why do the study? Endpoints. We look at endpoints. And if you're doing qualitative work, the endpoint would be the data. It would be the point at which you get the data and you've collected it all. even qualitative work has an end. It has to end at some point. What is it? When we look at quantitative endpoint, it should be a valid measurement of the concept of that's being studied. Clinical endpoints are a little bit different. Clinical endpoints should be clinically obvious and easy to understand. They also need to be easy to interpret. For example, a biomarker such as TNF alpha is much more difficult, and it's not a clinical endpoint because we don't know with TNF alpha, we can't compare it across populations easily. They're getting there. The biomarker space is being upgraded massively. But right now, you can't treat it like a hemoglobin A1C. We all know, at least in the US, the way we measure it, an A1C of 14 is too high, an A1C of 2 would be too low. And it lets us clearly delineate what's the meaning of the value and how should I interpret it. Whereas, again, with TNF alpha, it's affected by age, stress, chronic conditions, that type of thing. Next, we're moving on to statistics. If it's descriptive, your statistics still have to demonstrate some validity. You want to make sure you explain that. And power, it's the ability to detect if a statistical difference exists between the treatments. Typically, power is an 80% chance of noticing a difference. If your sample size cannot detect a change, then it's not big enough, or you need to choose a different statistical method. Sample size, you're going to describe it. You want to conceptualize this of how many people do I need and what types of changes am I looking at detecting? For example, in regression models, the less variables you have in the model, the lower the sample size is needed to detect a change. And then if you get into a very nuanced discussion of what sample size and what level of change is valid, those are considerations that need to be thought about ahead of time. And you also want to anticipate, what if I get to that number and can't detect a change? Is my data still valid, or do I need to look at it in a different modality? But plan that and have an idea of those numbers, because it'll really help guide you in terms of what types of questions to ask. Now it says the Southern Nursing Research Society is now the host. Am I good to switch over?
Hold on one second. Let me share the screen or make you a host so you can get the screen.
Perfect, not a problem. Thank you all. And this is cool because we haven't gotten to the case study yet. I am the host now.
Now you can
Yay!
see. Now.
Yay! All right. Thank you all. Everybody, thanks everybody for doing that. I really
Yeah.
appreciate it. Hang on, now I have to figure out host tools, share screen.
Yeah,
Okay.
go to share button.
Can you guys see my screen?
No.
No. Okay.
I do
so
not see it.
let's see, share screen options.
Yeah,
One person
share.
Yeah, it
Blind.
says one person can share.
Okay, did you try it? Okay, let me try. Maybe she gave it to me. Let's see.
And again, thanks everybody for bearing with us. I'm glad I tested this presentation out to make it 30 minutes-ish. Let's see here.
Hold on.
Oh, wait, here. I've got it now. Sorry.
You got
Eunice.
it?
I'm there.
Okay.
I got it. Yeah.
Good.
It's in a slightly different place than Teams.
you.
So, all right. Can everybody see it? Eunice, can you see my slide? It says the
Yes, I
Are you
do.
okay?
Yes. I see it now. Thank you.
Sure. Sydney, you can totally record this on your computer. All right. So this is just the slide that we talked about, and now we're going to
Same thing.
move to feasibility. Can you do it? The study population. This is the who and what are you competing with for access to the study population? Populations aren't limitless, and researchers are all working within other populations. If you're in a rural area, you have a limited number of rural adults, you aren't the only person that's likely studying them. Do you have enough of a population to recruit enough participants? Next, on the personnel side, do the investigators have enough time to carry out the study? You have a great idea, but you've got 5 other projects. Do you really have the time and to put into the study and to do it in a way that is accurate and that you maintain validity of data? Can you hire or move enough support staff if you're not just the only person performing the study? And how many support staff do you need? Do you have enough people to help you? And can you afford them? Space and storage. If you're doing paper studies with consent forms, if it's paper, how long do you have to keep them? Do you have a place to keep them? Can you afford to keep them? And can you keep them behind locks? If it's electronic, wherever you're working, do they have a space that has limited access that you can keep for, say, 7 years? Or will they say, we're going to keep charging you money to keep it there? Because that electronic space costs money, it costs electricity, and it costs personnel to maintain servers. Budget. This is something we're going to, if you're not familiar with budgets, reach out to people that have experience in this area, because did you set your budget appropriately? And 2 important questions to consider. How much does it cost now? And then how much will it cost when the study begins? Costs don't stay static. They're changing. They increase, sometimes they decrease, but will you still be able to afford buying out someone's salary or paying for a research assistant today? But what about if your study's 5 years long, 2 years from now, 3 years from now? Again, something to consider. Next, data. This is the part that I get really excited about. We have to ensure credibility and accuracy of data. In clinical trials, conceptualization of documentation and research is called a source document. It is typically signed and dated. It has to be thorough, complete, consistent, and accurate. It has to be documented at the time actions performed, generally not 2 days later, similar to the clinical charting. Don't wait a week to document a sick day visit from a patient. That can be paper or electronic. And the argument for source documents is that you have to have an audit trail and it needs to be accurate. It is much easier to fix an error earlier as you're monitoring and address it early than address it late. Another component to this is if your data is inaccurate, then the conclusions that you reach from studying the data can be inaccurate and can lead to further effects. It's different when the data that you've studied, because you've only looked at a certain sample, doesn't necessarily apply. Science goes forward and backwards. But if you have data that is inaccurate because you weren't careful and you weren't monitoring it, you can come to the wrong conclusions, and that can lead you on a different path for studying questions. It can also lead to further concerns down the road. Coding data, this is completely dependent on the study, and it depends on the needs, and you can code data any way you want to. Everybody has a different philosophy for coding data, different way they like to code things, but it needs to be consistent. For example, male and female can be coded as male and female categorically. We can use numerical values, 0 and 1, 10 and 15. It ultimately doesn't matter, but what you want to do is document the coding and understand why you made those decisions and don't change it. Now, you can change it if you change everything, but you have to be consistent with that change, and there has to be an audit trail. Now we're going to the case study. This is Dr. Tweety Bird's study, and Dr. Bird is aiming to study, does glucosamine improve knee pain in older adults with osteoarthritis? Dr. Bird is basing his study on the manifestations of osteoarthritis. For his population, for example, the inclusion criteria is an age over 50, arthritis. This is a scale criteria based on signs and symptoms. And the exclusion criteria is age less than 50, immobility, and an inability to speak or read English. We have some selection bias. It is limited to English speakers. And with the older adults, over 50 is a very large age range. It can, for example, you could get a lot of younger 50-year-olds, or you could get a lot of 70-year-olds. And what's the difference with those? Does not having a good range of age show us what's going on? And then when we remove those with immobility, that have mobility issues, what we are taking out is folks that can't move. Now, it could be that the arthritis damage may be too much, and we can say that that's the largest confounding factor. But then your question is the glucosamine relevant if it can't apply to them? These are some considerations to think about as you're developing your inclusion and your exclusion criteria. Dr. Bird's study personnel. Dr. Bird is a DNP. They are a principal investigator. Sylvester Cat is the nurse. They're a study RN. And he's able to pay some money for a research assistant named Daffy Duck. And the protocol should clearly define the tasks and the overlap of responsibilities. Even with only 3 personnel, it shouldn't all be the same. And people take vacations. And in that case, Daffy Duck is going to cover some of Sylvester Cat's duties. But because Sylvester the Cat is a study nurse, Daffy might not be able to do everything. Dr. Bird may have to cover some of those duties as a DNP. The visit schedule. You always want to have a schedule of what you're doing and how you're collecting the data. And the pre-screening phone call. What's going on? You have in the study, we have an initial visit where we have consent, eligibility, past medical history, medications, the questionnaire. We have a first study visit with study medications and other study procedures, follow-up visits. Say for this one, it's 3 visits, 1 month apart, and plus or minus 5 days. As you're developing research, give yourself some time and have a screening window and think about that screening window. When does the data change? When does it matter? You can go to the research literature and see what others are doing, because sometimes a 2-week window is okay. A 2-month window may or may not, may be too long. It's something to consider, and also a final visit. The endpoints, and these are just made up. Make sure the scales are valid in your population. But for pain scale, let's say we're going to improve by 10 points, functionality by 5 points, and symptoms by 15 points. Before you develop a study, consider, are these endpoints valid? And will they show a difference, and is it meaningful? Another component is sometimes the scales haven't been studied in your patient population. You can use them, but just document why. Explain why you're using them. You need to use a scale. It's been used in other populations. Here's the validity. It has content validity. We're going to apply it to this group. As long as you explain it and then evaluate some of those components as you're collecting the data, it ensures quality. Next, recruitment. Dr. Bird has determined that we have an little n sample of 100. And the cool thing is nowadays you can include that pre-screening data collection into your protocol. Dr. Bird is doing this. It's written, but every university, like for example, Luna University states that the pre-screening data cannot include occupation. Include the pre-screening data in the protocol as you send it to IRB so that you can collect this data. This gives you a treasure trove of information. It's de-identified. What it lets you study is, are your recruiting methods efficient and do they work? For example, the cost and number of events, health fairs, flyers, Facebook, Google Ads, and it also lets you look at the demographics of participants, because is it more cost effective to go use health flyers or Facebook? And which one of those, let's say you get a lot in either method, how many of those actually end up being enrolled in the study? 'Cause the next slide will talk about the differences there. And this is an example using Dr. Bird as recruitment. Dr. Bird's going to do formative assessments at 2 months. Let's say we start off with 40 participants at the events, right? 30 males, 10 females. Then when they call out, we reach 30 participants, 20 men or 20 males, 10 females, 25 participants then agree to enroll, 15 males, 10 females, and 20 actually show up for their appointments. It's about 50 or 10 males, 10 females. But when we get to the enrollment numbers, we only have 10 enrolled, 2 males, 8 females. This lets you evaluate what you're doing and who's coming in. What's the burden? Why are we, and you might not know these answers as you're doing the study, but even if you can't find an answer, it's good to think about and consider. It also helps you write your limitations. For example, here you've recruited 8 males, or no, sorry, I apologize. I read that wrong. 8 females and 2 males. But it really it tells a story here. It's a made up story right now, but it does tell you and lets you consider what factors are affecting things and then getting to the why. Next, Dr. Bird studied the data. Dr. Bird has chosen to use electronic data capture software, EDC, a case report form. It's designed to capture relevant data that's de-identified. And on the right, we have an example of a case report form. Source documentation is the initial data. A case report form is the organization. And electronic forms can prevent typos. For example, in this one, what you would do is you'd have a time to enter date, SBP for systolic blood pressure. You only give 3 number fields. Diastolic, same theory, click and tap, height in centimeters. We had, I think with the EPI study, when we were QCing data, we had it in inches. It was supposed to be in inches, someone wrote centimeters. So we had a couple folks that were 8 feet tall. Weight and in pounds, be sure to be precise with the measurements. And because it's easy if you're using multiple scales, or say you have when you're checking someone's height and you have inches and centimeters, it's really easy to sometimes, especially if the research assistant isn't as knowledgeable or just quickly going through, it's easy to make a mistake. And you're going to have the vital signs version. You're going to version it. What version is it, and what's the date that it's active? And the reason we version things is because information sometimes needs to change, and you can change it, but this allows you to find out and to follow with an audit trail when you changed it and what data it applies to. And a case report form in terms of organizationally can be demographics, vital signs, pain, and in this study, pain, functionality, and symptoms. Next, coding and standardization. Standardization, when we look at clinical data interchange standards, CDIS is widely used. These are global standards. You can Google them. They allow for the ability to send data to regulatory agencies and also use them for analysis. When we look at medical coding, ICD-10 is good because it's consistent and it's global. Medications, this can sometimes be the bane of anyone's existence because how do you classify them? Generic or branded? The WHO has a drug dictionary enhanced. And what do you want to use to make the data usable for medications? Adverse drug reactions are also classified by the Medical Dictionary for Regulatory Activities. And with medications, for example, in one of the studies, they say you can only use the generic. It doesn't matter if someone's saying they're using the branded product. If it's Advil, it's ibuprofen to ensure consistency. Because let's say we're looking at something relatively simple as Norvasc. Norvasc can be known as Norvasc, amlodipine, or amlodipine vesicate. Do you care that that vesicate, which is the salt part, is in the drug name? Depending on the study, that sometimes might be yes, that sometimes might be no. What are you studying? And is it relevant? Make a decision and then keep it consistent. Because I've seen data where if it's not consistent, it's really hard to use it when the medication names are spelled 10 different ways. Because you have to have someone that can understand the spelling errors and know what the drugs are to find them and then to organize them. All right. Dr. Bird is wanting to update a questionnaire. When we look at updating questionnaires, we have to do this sometimes, right? Sometimes data doesn't work. Oh, or we started the study and, oh, we found out that a better form is used. And we're going to use a functional status case report form and only change data going forward. You can fix older data after it's collected. On the right, we see that CRF number 1, version 1, and it's good for 10/25/2016. We have question 1, 2, 3, and 4. And when we look at the coding, we see that it is raw. Questions 2 and 4 are entered raw with yes is 1, no is 0. But you'll see on the parentheses, 2 and 4 will ultimately get recoded. When they design questionnaires, when we look at questionnaires, they will sometimes have reverse coding to ensure the validity and accuracy of data, and also to trigger patients or participants to actually read it. Because if someone's just saying yes to everything, they want to get through it quickly. Is it really valid? And you should see some questions where it changes, especially for example, the geriatric depression scale has questions where a yes would be reverse coded in order to compare and keep validity. And also so that someone just doesn't say yes to everything. But Dr. Bird then has decided to change it, right? We're going to change the questionnaire. Okay. And we're going to automatically include the reverse coding. You can do this where you can electronically say, I'm going to include the reverse codes all at once, right? So when we compare questions 2 and 4 from the first one to the second one, we see in one it's yes is 1 and no is 0, and then they'll have to recode it. But in the second questionnaire, the yes is automatically a 0. It's coded correctly. And Dr. Bird is going to be very careful about what the data looks like and what it should look like outside of the electronic data capture system. And this is an example of variable coding, and we'll have a note here that says recode questions 2 and 4 for version 1. When we compare the two cases, we see that case 4 is the original, case 45 is the new. And what you see is the way Dr. Bird has organized it. We have them easily separated out, which allows you to combine after the data is collected to then combine the variables. If you want to combine them, questions 5 and 6 will always be, for any of the old cases, would automatically just be missing data, not 0. 1 and 3 can be kept the same, but 2 and 4 have to be recoded before they get combined. And this is something to be careful about and keep it separate. So you could theoretically, with the questions that don't change, keep them as the same variable name, but you want to make sure you have different naming conventions for data that is different, because the type is different and how you're using the data is different. This next example is what happens when Dr. Bird doesn't keep the forms separate. Right? We see cases 4, 10, and 11 have, this is before the update, have different meanings. Questions 2 and 4 have different meanings than cases 42 and 45. And we know this because of the date of the change. The date of the change is May 26th, 2027. And when we look at this, we can see it. Normally the date isn't added to the case number. This was just sort of easily done. But how do you fix this data? It's a lot tougher when the variable names are all the same, because then you have to find out, you have to separate the cases, know which cases you're separating, and change the data, because 4, 10, and 11 have to have recodes for 2 and 4. How do you keep that separate? How do you keep track of it? And how do you ensure accuracy in data? And then where do you document it? Where do you document the change? How are you documenting when you did it? What changed? How many cases changed? And what's important there? Because it's easy to make a mistake. And then if you combine data in different types, you can easily end up with an inaccurate conclusion. Data review. Dr. Bird wants to keep an audit trail. Sylvester, the study nurse, is entering data in real time, and Daffy, the research assistant, is verifying it. Sometimes we don't have a lot of the personnel to manage these different steps. You want people that are performing the review to be different than the person that entered the data. If it's just a 1-person or 2-person study, you can do that, separate it by time, and then review the data in a different way than you entered it. Have those controls, because mistakes are easy to make, and we all look at data slightly differently. We all have different processes. As long as you can make an audit trail, you're okay. For example, errors, this is a real easy one. Entered a date before the study started. On paper, you can just cross it off. Sometimes you click the wrong button. The incorrect name of a medication, aminoterone instead of amiodarone, and missing data. Missing data electronically is easier to manage, because you can, in a case report form, you can say you absolutely have to put data in here. You can't skip it. Whereas on paper, it's sometimes easier to skip it. It's also electronically, if you don't have that option, you can miss data that way too. And then you can't get, if you don't evaluate it to see how many people are administering it and what's the pattern in the error, you're going to continually have a lot of missing data. And sometimes it might just be the way the question's worded. It's too easy for someone to miss. It's not a blame. It's a look at the process and fix it. Discrepancies. This is when we look at data cleaning, this is reviewing them, and we look at reviewing them for missingness. Incorrect data. I've actually seen diastolics greater than systolics, and that's because of the way forms were designed, where it had electronically pulse, systolic, diastolic, whereas the machine says systolic, diastolic, pulse. And sometimes if folks aren't trained medically, they're going to just write it down, and it's an easy mistake to make. errors in scoring. Now, I will say caveat that not easy for someone like us, for us as nurses, but again, easy because you just kind of get in the zone. And if it's an error, then change the source. You can change the source document, but you have to keep a record of the change. Then when we look at cleaning, we're looking at changing the data from its raw form, not all of it, to making it usable. It has to be usable to answer your question. For example, if Dr. Bird wants to perform ANOVAs, he's decided to change some categorical data into numeric data because categorical data won't work in an ANOVA. And this can happen because you say, oh, I've got my statistical plan, and then I have a variable. Oh, I forgot to code it. I coded it categorically, not numerically, or I'd like to use this variable. Can I do something with it? Missingness. This gets also very tricky, and you can always talk to a statistician unless you are good at imputation and you have a good stats background. But if there's too much missingness, you can absolutely use imputation, but create a new variable in the data set. Because you still want to keep that raw data to come back to, or that data initially, in case someone wants to look at it and you can explain why. Don't go back and change the case report form in this case. You'll change it, create a new variable, use your imputation, and run your analysis separately. This is the soft database lock. Soft meaning soft or interim. This is before the final lock, and you kind of want to consider it as a snapshot. You're doing a study, you've collected, let's say, half your data, and you want to evaluate how things are going, the progress, and also see if you need to make any changes. For example, here, Dr. Bird can change a functional status questionnaire. And if you look at it from the interim, you have the opportunity to publish initial papers of what you're doing, what's working, why is it working, what does the preliminary data say, and what does it suggest? That's all very important work because it's not necessarily final, but you can spur ideas to others. You'll go, oh, that's cool, that's preliminarily, I can try this in my patient population. And the final lock, thinking of this as this is the end, no more changes. The data is ready for any and all of the analysis that you will do. It could be years later. And Dr. Bird has officially completed the study. He's performed statistical tests and he's reported all of his findings in journals, and no more changes allowed here though. Now you could theoretically share the data if it's de-identified, if you have agreements and someone can create other ideas off it and change variables, but your data, no more changing it. And someone should have an audit trail from the initial data entry to that final piece. You should be able to follow it. So I could theoretically look in there and go, I'm studying case 5, following the data, saying, oh, you had to rescore part 1 of something, and I'm able to see it throughout and able to track it. And in conclusion, clinical trial frameworks enable the accurate collection and analysis of data. How do we get there? How do you want to do it? Read what other people are doing. Even if you're not setting it up in a clinical trial way, go to clinicaltrials.gov. They have a ton of protocols in all different areas. They have a lot of inclusion and exclusion criteria. Look at what the criteria are and kind of why. Practice. Research only gets better the more you practice, and find people to mentor you. I've had some really good mentors, and one of mine, Dr. Judy O'Giles, I always quote her, has always told me to know my N and my sample. And I've had that in my brain anytime I conceptualize data. And finally, I have my references. So I'm going to shout out, actually, the 3 at the bottom. The Kurakowski article is in Digital Health Interventions. It's great. They have a great image of recruiting and selection bias in digital research. The Lewin Davis, it's a book. And if you're interested in research, it's a great way to explain the process. The Oronsky article, talks about data management and really does a nice job in explaining data from collection to the end and different types of practices or where to go and find some of these resources and what you have to do. And that's it. Thank you, Eunice.
Thank you so much, Dr. Large. That was a very great presentation. We still have some few minutes for questions. If anyone
Yeah.
has any question, please. I'm sure she's ready to take our questions.
No, I have patho students that I have office hours for pathophysiology master's students. So,
Okay.
you know,
Thank you.
but if anyone has any questions, feel free. This is something I enjoy. If not, it's totally okay.
Any question? Please, let's feel free to ask. I don't see any hand here. Well,
And Eunice, should I make you the host so that you can save the recording?
yes.
Okay, so let me see. How do I do that? More. Host controls. Hang on. So. All right, Eunice, where do I go to change the host? Because I'm not used to
If you go to more,
more. Okay.
yeah, and let's see.
Host controls.
Yes, I think that one.
And then request.
If you hit the three dots on the side of the person you want it to, it should come
Yes.
up of change host.
That's
Okay,
the
let
one
me
that
thank
says
you
more.
because the three dots on more, right?
Yeah. Look to
And-
see.
Notes. Captions, pause recording, notes, whiteboard, reset to default. That's
So
not
it's
it.
not showing anything about making a post. I don't know if Casey is still here. Maybe she can do it.
Let me
Oh,
try.
Okay.
Sure, thanks. Okay, so Charlotte has a question. Training
Yeah.
opportunities. I don't actually know that because I've only gotten my experience through doing and a lot of clinical trial work is practice while doing. And if you're preparing for your early clinical trial, reach out to people that have done them and ask how they've done them. Again, clinicaltrials.gov is a good place to really see what people are doing in your area. And in terms of the data side, if you have any questions about that, I love that part. But it's a lot of learn by doing and finding good mentorship. Now, there might be some in, there's actually the, hang on, let me try to find it. I think it's called ACRP. ACRP. It is the Association of Clinical Trial or of Clinical Research Professionals. I'm going to paste this in the chat. They have a lot of good education information. And they connect you with certifications and how to do them. And they have events and resources about clinical research. They're really good. And we've had some folks where we get that certification. Now if you're starting your own clinical trial, you're going to be a little busy, but those are great resources to look at and they really help develop folks. And Eunice, did you guys get it?
Casey, what do you think?
I can't because you have to do it. You just go
Yeah.
to the three dots when you see the participants, and then it would once you click on that, it should say change host.
Okay,
Okay.
cool.
So
wait.
okay, it's definitely doing that because when I click on that, I do not see change host or anything about host.
Oh, wait, so no, so hang on. Let me
It should
change
be
here.
Stephanie.
No, there we go. It's separate. Make host. There we go.
Yeah. Mhm.
Here we go.
Yeah, I changed it to you because I knew we were having
Okay.
issues, so I just wanted to make
No.
it so that
I
you were
have
able to
the-
present.
I apologize because we normally use Teams. It's between the teams and that's in terms of design, going from one
Okay.
design electronically to another. So
Okay, that's okay.
anyone else have any questions? If not, that's totally cool. And thank you guys so much for giving me this opportunity to talk to y'all. I really appreciate it.
Thank you so much, Dr. Large, and thank you for everyone that came for this webinar. Oh, thank you so much. Thank you. Thank you. Casey, we appreciate your help. Thank you so much.